Hello and welcome. I'm Dr. Ingvild Olsen, the Director for the Center for Substance Abuse Treatment here at SAMHSA. We are very pleased to be able to offer this webinar as you prepare your FY22 application for the SOAR grant program. As you know, the SOAR program aims to address the overdose epidemic by increasing access to treatment using FDA-approved medications for the treatment of opioid use disorder, reduce unmet treatment needs, and reduce overdose-related deaths through the provision of prevention, treatment, and recovery activities for opioid use disorder. Using SOAR funds, states and territories have implemented evidence-based practices using several effective and innovative approaches over the last several years. These approaches have resulted in positive outcomes, such as significant increases in client engagement, satisfaction, and retention in care, enhanced transitions for clients re-entering communities from criminal justice settings or other rehabilitative settings, increased naloxone availability, improved integration of wraparound recovery support services, successful family reunification and improved outcomes of child welfare involvement, and expanded access to on-demand treatment. While the SOAR grants have had positive impact across the country, as you are likely aware, we are continuing to lose too many lives to overdose. Provisional data from the CDC indicate that over 100,000, close to 105,000 now, people have lost their lives in the 12-month period that ended last October. We've also seen that some communities are being hit harder by overdoses compared to others. We also know that a proven strategy to reduce overdose deaths is education on and purchase and distribution of naloxone, the medication and a medication that reverses opioid-related overdoses to save lives. And through SOAR funding and other sources, states have been providing naloxone to their communities for some time. But the significant increase in fentanyl-driven overdose deaths that have been accelerated by the COVID-19 pandemic means we need to do more. And that is why, as part of the FY22 SOAR funding announcement, we've included a naloxone distribution and saturation plan that particularly pays attention to areas and communities with high rates of overdose mortality. To support you in fulfilling the plan and the requirements that are in the application, SAMHSA has partnered with the Opioid Response Network, ORN, to provide you free training modules. These modules include an overview of a modeling study to estimate the number of naloxone kits needed to reduce overdose risk, perspectives from urban and rural settings, and insights from the recovery community. We hope that these modules provide valuable information and insight as you develop your naloxone distribution and saturation plans. We so look forward to continuing to work with you and everyone in every community across the country to make sure that we are continuing to save lives of those impacted by this overdose crisis. Thank you.
Welcome to this Opioid Response Network webinar entitled Scaling Up Overdose Education and Naloxone Distribution, Lessons Learned in Kentucky. I'm Hannah Knutson. I'm a faculty member in the Department of Behavioral Science at the University of Kentucky, and I so appreciate your time today, where I'm going to share some of the lessons we've learned as we've worked to expand overdose education and naloxone distribution in our state. This webinar has 4 main objectives in terms of its agenda. First, I'll describe the context for scaling up overdose education and naloxone distribution in Kentucky. Then I'll outline some of the key elements of our OEND model. I'll then turn to explaining our approach to scaling it up across Kentucky communities, and I'll finish by highlighting some of the key lessons that we've learned as we've done this work over the past 2 years. But before I get started, I just want to share that I have no conflicts of interest to disclose today. Let's turn to the context for scaling up overdose education and naloxone distribution in the state of Kentucky. Our state has been historically one of the hardest hit by the opioid epidemic. We have lost too many of our residents to opioid overdose deaths. But what you can see in this map is that overdose deaths do not occur uniformly across our state. They are clustered in these darker red counties. Some of them are in the central part of our state, which is Lexington and the surrounding counties around Lexington, as well as Louisville, northern Kentucky, which is across the river from Cincinnati, and then in some of the eastern counties in our state. But The high rate of overdose deaths really encouraged us to apply to be one of the sites in the Healing Communities study. So the Healing Communities Study, or HCS, is part of the National Institutes of Health HEAL initiative, and HEAL stands for Helping to End Addiction Long Term. The Healing Communities Study is a cluster randomized waitlist controlled clinical trial at the community level. That's kind of a big mouthful. Really what it means is that we have 67 communities that have been randomized into 2 waves. Those communities are in the states of Kentucky, Massachusetts, New York, and Ohio. But eventually all of the communities will get to experience the community level intervention. We've just got half of them that are starting first, and then we'll reach the second wave of communities starting in July of 2022. Our primary aim in the Healing Communities Study is to test the effectiveness of a community level intervention on reducing opioid overdose deaths. Here in Kentucky, we're focusing our work on 16 counties. These counties had a total of 764 opioid-related overdose deaths in 2017, which was the most recent data at the time that we wrote our grant application. That translates to an overdose death rate of 45.7 deaths per 100,000 residents. You may be looking at this map and thinking, these 16 communities, that's not very much of our state. But actually, those 16 counties represent 1.8 million people, which is about 41% of our total state population. I'm going to spend just a very short amount of time talking about the Communities That Heal intervention, which is the intervention being tested in the Healing Communities Study. It has 3 primary components to it. There's a community engagement component, then there's the Opioid Overdose Reduction Continuum of Care approach, or the ORCCA, and then there's a series of communication campaigns. For the community engagement piece of the study, local community coalitions and the Healing Communities Study research teams are collaborating through a multi-phase process. They look at the resources currently available in the landscape within each community. They use data to make decisions about evidence-based practices to implement, and then go through a series of steps to create a community action plan. What's fundamental to understand is that the coalitions are setting the priorities for which EBPs to implement in each of these communities. They prioritize venues, and in some cases even prioritize specific organizations for EBP implementation. The coalitions are choosing from the Opioid Overdose Reduction Continuum of Care approach, or the ORCCA. We think about the ORCCA as having 3 main menus, the first being Opioid Overdose Prevention, Education, and Naloxone Distribution, or OEND, for high-risk populations. And that's what I'm really going to focus the majority of this webinar on. But I did want to highlight that there's 2 other menus of EBPs that the study is working on. The second menu focuses on medications for opioid use disorder, expanding access to those medications, increasing linkage to those medications, and working with agencies to improve retention on medication for opioid use disorder. And then the third menu focuses on safer opioid prescribing and dispensing. So coalitions use the ORCCA to set priorities. And then there's a series of communication campaigns that are focusing on building public support for the evidence-based practices. So this is actually an example from one of our Kentucky communities where we're trying to build public support for carrying naloxone and helping community members know where they can receive naloxone, and as well as education about how to use it. And here the primary messages focus on how traditional first responders certainly play a part. So a local member of EMS and a firefighter are depicted here. But the last is a community member. He's actually on the community coalition in this county as we try to build support for expanding overdose education and naloxone distribution in the community. So those are the 3 components of the intervention. What's interesting is that the intervention itself doesn't necessarily pre-specify how we have to go about implementing overdose education and naloxone distribution. In essence, the manual for the Communities That Heal intervention has sort of a black box, if you will, of how to go about implementing. And our experience so far is that it's actually not a single black box. There are many black boxes. There's no single path to achieving implementation of this evidence-based practice. But we've started with a framework to guide our work, and then from that framework, we adapt it to local needs, both at the community level as well as specific organizational needs. And our perspective is that we can always do better. So we're always thinking about how we can improve the implementation process so that we can partner with more agencies, meet their needs, and reach more people with overdose education and naloxone distribution. In terms of our Kentucky model for OEND, I think about it as a naloxone hub that has many spokes. So our central hub is located at the Center on Drug and Alcohol Research at the University of Kentucky in Lexington. And then we are building partnerships with agencies across our Wave 1 communities in those 8 counties, and later we'll be reaching out to organizations in the Wave 2 counties. And we've really tried to cast a wide net in terms of the types of partner organizations we work with. We certainly partner with medication for opioid use disorder treatment programs, with other substance use disorder treatment programs and recovery organizations. But we also partner with health departments and syringe service programs, healthcare organizations, social services, and then there's a sizable criminal justice component. So we have partnerships with jails, departments of probation and parole, home incarceration, pretrial services, and so forth. So our naloxone hub serves 3 primary functions. Our naloxone hub is responsible for ordering naloxone for our partner agencies, for dispensing it to those partners, and monitoring expiration dates. The hub also provides overdose education resources as well as ongoing technical assistance. And I wanted to highlight that really that efforts in designing our naloxone hub have been led by Dr. Trish Freeman and Dr. Doug Euler at the University of Kentucky. And the photograph on the right is Josie Watson. Josie is our naloxone coordinator, and she does all of the ordering and dispensing to make sure that our partner agencies have plenty of naloxone to distribute in their communities. And then each of the partner agencies has 3 primary roles as well. So they receive the naloxone shipments from the hub. Their agency staff train individuals in overdose prevention and overdose response, and then their agency staff do the actual distribution of naloxone to the individuals that they've just trained. So that all sounds very simple and clear, but our experience has been that OEND, you can have a model, but that doesn't necessarily provide you with a map to make sure that you achieve implementation. So what have we been doing to promote implementation of overdose education and naloxone distribution? We started with an implementation science framework. It's called the EPIS Framework, and it was designed by Gregory Ahrens and colleagues. And the important piece of the EPIS Framework is it talks about how you need to think about different strategies depending on what stage of the implementation process that you're in. So it starts with an exploration phase, where an organization is just starting to learn about a new evidence-based practice. Then those agencies move into preparing, the preparation phase, trying to make sure all the pieces are in place so that their implementation will be successful. And after all of the planning and preparation, they move into implementation, and then hopefully into a sustainment phase where the evidence-based practice is maintained over time. For our work at the University of Kentucky, we've been thinking about this EPIS model as happening at 2 different levels. We've had to think about how EPIS applies to designing our centralized naloxone hub, as well as our work with partner agencies. So for our centralized hub in Lexington, the exploration phase really had 3 main components. We of course needed to have funding for this initiative, and so that comes from our grant, and it supports staffing as well as purchasing supplies to support overdose education and naloxone distribution. But we also needed to do some work to understand the relevant statutes and regulations in our state, and we sought input from regulatory experts to make sure that the program we were designing would be compliant with state law. So in Kentucky, there's 2 regulations that have provided the regulatory underpinnings to allow for us to build an OEND program. The first just really allowed for naloxone in the first place. That's a 217.182. And then a later regulation, 217.186, allows providers to dispense naloxone by standing order to an individual or to an agency. And this really was the foundation upon which our naloxone program has been designed. So that regulation allows for standing order agreements, or an SOA. So standing order agreements serve effectively as a prescription. It allows for the dispensing of naloxone to our partner agencies and authorizes those partner agencies to hold on to that naloxone supply and then distribute it to any person who has completed bystander training that encompasses overdose prevention, recognition, and response. A couple other key points about the standing order agreements. So it does need to be signed by a healthcare provider. In our case, all of our standing order agreements are signed by an addiction psychiatrist at the University of Kentucky named Michelle Loftwall. In addition, our partner agencies have to provide us with the list of all the individuals who will be involved in the overdose education and naloxone distribution at their site and keep that list up to date. But as part of our exploration phase, we thought it was really important to get input from experts, regulatory experts in our state. So we reached out to Mike Rodman, who's the executive director of the Kentucky Board of Medical Licensure. He reviewed our template to make sure we were complying with Kentucky state law. So if you're doing this in another state, you would need to first figure out what the state regulations look like, and there may even be local regulations that come into play. For us in Kentucky, our standing order agreement requires agencies to provide overdose education training that consists of at least 7 elements, and you can see them listed here. So to comply with our standing order agreement, the agency has to agree to provide overdose education training that identifies the risk factors for opioid overdose, strategies to prevent overdose, the signs of an opioid overdose, steps in responding to an overdose, information about naloxone, and the procedure to administer naloxone. And then lastly, that training needs to include information about how to properly store the medication and to keep an eye on the expiration of the naloxone. So after we did that exploration work, as we started to move into a preparation phase, we had lots of activities to get our centralized hub off the ground. So certainly we needed to develop templates for our standing order agreements. We spent also a lot of time developing standard operating procedures, or SOPs, about how the hub would operate. So we have SOPs that cover how to purchase naloxone, how we store it at our hub, our processes for monitoring expiration dates of those units of naloxone. We also have SOPs around how it gets transferred to agencies, as well as a whole set of SOPs around the implementation processes for engaging with partner organizations to scale up OEND in their agencies. In addition to SOPs, we did a lot of work around developing and tailoring overdose education resources. And then it was also important for us, because it is a research study, to not only be able to monitor implementation in terms of the partnerships we were developing, but we also needed a system to be able to monitor how much naloxone we're shipping out, how much is being distributed, so that we could make sure our partner agencies had enough supply of naloxone to meet their needs. And then, of course, we needed to hire and train the staff who would work in the hub. Once we did all of that preparation work, then we moved on to implementation, which is where we are now. Our hub is constantly working to maintain our supplies, engage with potential partners around implementation, and then is providing that ongoing technical assistance. And we'll be starting to move soon into a sustainment phase for our Wave 1 communities. A lot of the work we're doing in terms of our hub is working with state level partners to identify resources to help agencies sustain OEND after the study. In terms of engaging partners in the implementation of OEND, we also use this EPIS framework in thinking about how we approach partner agencies. Foundational to all of this work is a team of implementation facilitators, and they are pictured here. And I am so proud of what they have achieved so far. They do all of the work to recruit potential partner agencies. They work with agencies around the initial implementation, and then they provide ongoing technical assistance. So as we get started with a new partner agency in that exploration phase, there's really simple recruitment that we do. Our implementation facilitators have a short email template that they rely upon that really focuses heavily on what the healing community study can provide to the agency. And then for those that maybe need a little more nudging, they will engage in phone follow-up as needed. Once a potential partner agency expresses interest, the implementation facilitator will set up an introductory meeting via Zoom. And I suppose this is one of the few silver linings of the COVID-19 pandemic, is that initially we had planned to do all of this work in person, but we of course had to pivot and move to a remote means of facilitation. And I actually think because we aren't having to travel all across the state, our facilitators have been able to reach more agencies than we had originally planned on. But at that introductory meeting, an implementation facilitator starts with a very short slide set. And by very short, I mean exactly 6 slides. We don't really want to overwhelm them with too much information. We want a very brief introduction and to gauge their interest in partnering with the healing community study. We then quickly move into the preparation phase, and the implementation facilitators engage in a discussion with the partner agency about what the workflow might look like for their agency. So some of the key questions they're trying to figure out are, who are the staff that would deliver overdose education and naloxone distribution? What kind of overdose education would the agency prefer to use? Are they going to target everyone served by the agency, or maybe just focus on particularly high-risk individuals? Kind of all of those workflow issues about how the nuts and bolts of the overdose education and naloxone distribution are going to work. After one meeting or two meetings to work out the workflow issues, the implementation facilitator makes sure that the agency signs our standing order agreement. So a leader from the agency needs to sign that and identify the staff who will be involved, and then our addiction psychiatrist signs the standing order agreement so that it's fully executed. And then there's an additional training led by the central naloxone coordinator about how the agency will receive the shipment and what they need to do in terms of documenting the naloxone that they're distributing. So then a partner agency moves into implementation, and really here's where agency staff take over. They work with the clients they serve to provide the overdose education, to distribute the naloxone, and then document the units of naloxone that are being distributed. But our implementation facilitators are working towards ongoing follow-up with each of our partner agencies. We start out on a monthly schedule, and if an agency is doing really well, we'll move to a quarterly follow-up schedule. And those follow-up meetings are also done via Zoom. It's an opportunity for us to provide feedback to the agency. We share with them the data on how much naloxone we've shipped to them, how much they have distributed so far. We love to celebrate their successes, but if there are challenges, the implementation facilitator is there to work on troubleshooting the problems, and it's an opportunity to provide any additional training as needed. And then our naloxone coordinator, her role throughout this implementation phase is to continue to replenish the supply of naloxone, and as units reach their expiration date, work with the partner agency to bring back those expired units. And then finally, partner agencies move into sustainment, and we're not quite here yet in terms of the study, but we'll be working with partner agencies to identify funding for ongoing overdose education and naloxone distribution after the study ends, and also encouraging them to institutionalize OEND, so embedding it within their agency policies and standard operating procedures. We have learned a lot, and that's where I'm going to spend the rest of this webinar, is a series of lessons that we've learned by doing this work to scale up overdose education and naloxone distribution in our 8 Wave 1 counties. The first lesson that I hope will convince you to think about how you can scale up overdose education and naloxone distribution in your community is that there has just been incredibly strong interest across our communities to engage with us. I was so scared before we started this work that we would not be able to find agencies that wanted to partner with us. So we launched in April of 2020, just as the COVID-19 pandemic was getting underway. And over a 2-year period, we have attempted implementation with 244 locations in 8 counties. And we've actually achieved implementation in 170 of those locations. So that's almost 3/4 of the agencies that we've contacted. We've been able to find partners in all 8 Wave 1 counties. And actually the average partner locations per county has been 21 locations per county. As further evidence of the strong interest that we've found in our communities, this slide shows how much naloxone we have shipped, that's the dispensed bar, to our partner locations, and how much those partners have distributed. So as of mid-April 2022, our 170 partners have received more than 47,000 units of naloxone, and they've distributed about 3/4 of that. So 35,000 units have been distributed by those agency partners to the people that they serve. In addition to strong interest across communities, we've also had a lot of interest across different sectors. So this pie chart summarizes the types of partners that we have engaged in our OEND program. So the largest percentage, 33% of our partners, are either syringe service programs or health departments. So in Kentucky, syringe service programs are always embedded within health departments, but we also have some health departments that are scaling up naloxone outside of the syringe service program specifically. And then the next largest sector is the treatment sector, but we've also had good interest from criminal justice partners, as well as local overdose quick response teams. And then we have a variety of other kinds of partners, social service agencies, medical clinics, EMS, and so forth. So there's just been a real outpouring of interest and effort on the part of partners to implement OEND. The third lesson I wanted to highlight today, though, is that we learned fairly quickly that a single standing order agreement template really wasn't going to meet the needs of all of our partner agencies. Early on, with some of our initial agencies that we contacted, some of them raised concerns that they actually sometimes experience overdoses located on their premises. And so our initial template for the standing order agreement didn't really allow for on-site administration of naloxone. So we worked quickly to amend our standing order agreement. So we have a version that allows for both distribution as well as on-site administration. And we actually ship a separate small supply of naloxone that's labeled specifically for the on-site overdose response, as well as then the larger supply typically for what they're going to distribute after they've trained individuals with the overdose education. We also learned later on that, we were starting to engage with organizations that had their own medical providers. And so there was interest sometimes by agencies to have their own prescriber involved in OEND. So we developed an internal prescriptive authority model that would allow that prescriber to be the person who signs the standing order agreement instead of our University of Kentucky physician. Now, we at UK still provide overdose education resources. We still order naloxone on behalf of these partners, but rather than the naloxone shipping from our hub, it actually directly is shipped by Emergent Biosolutions to the agency. The other difference in this model for agencies that want to use internal prescriptive authority is the agency has to be willing to label the naloxone themselves, and they need to take on the responsibility of monitoring the expiration dates for those units of naloxone. We have learned a lot, though, about overdose education and really the need to have multiple options from which the agencies can choose. Sometimes agencies will choose just one of these options, or they may even choose a combination of them. So we knew from the start that we needed to develop overdose education options that would align with our state regulations. And we thought that a video option would ensure fidelity, so everybody would see the same content. And so we planned initially on a single option. We built a partnership with Get Naloxone Now, and they have an interactive overdose education that's available online. And some of our initial agencies were very receptive to Get Naloxone Now, and they liked it quite a lot. But we also had some agencies raise some concerns. Some of those concerns were about how long it took to complete the overdose education. It takes about 20 minutes. Some agencies also were concerned about the way that it could only be done by individuals, that it couldn't be done in a group setting because of the interactive components of the training. And then it does require a person to be connected to the internet, and for some of our agencies, that was a barrier. So we decided to develop a second option. We developed a video specifically for the Healing Community Study about how to use naloxone. It is shorter. It's only about 9 minutes instead of 20. And because it is just a standalone video, it can be shown in a group setting, which was attractive for some of our partner agencies. We do have it posted on YouTube, but because of the internet connectivity issue, we also load it directly onto computer tablets that we provide to agencies. So that allows them to be able to show the video even if they don't have access to the internet. But there was more that we needed to do in terms of overdose education. We knew that we wanted a Spanish version, and we developed that pretty quickly by identifying a company that specializes in medical translation. But we had partner agencies making requests about additional languages, and we wanted them to be able to reach as many people as possible. So we have translated the HCS video into Spanish, Arabic, Swahili, and Kenya-Rwanda, which is the national language of the country of Rwanda. But we still weren't done yet. So we had some partner agencies who really didn't want to use a video. They wanted their staff to be more involved. They said our staff can use overdose education as an opportunity to build rapport with our patients. So for those agencies, they can use a trifold pamphlet that we have developed. And if it is verbally reviewed with a patient and covered in its entirety, it will meet the requirements of the 7 elements in our standing order agreement. And we've also translated the pamphlet into all the other languages that our video is available in. Another lesson we've learned through this experience, though, is that technology can be challenging for some agencies. We provide computer tablets at no cost to our partner agencies. The tablets really serve 2 functions. They can house the videos, as well as they provide the system for entering data on distribution of naloxone. So we use REDCap, which is a survey management system. It ends up for the user looking like any other web survey. but it allows an agency to enter information, a really short set of information every time a unit of naloxone is distributed to someone. But we have found that the data entry piece can be challenging. Although REDCap can be used without being connected to the internet, without Wi-Fi, we do need agencies to get connected periodically with those tablets to Wi-Fi so that their data can get synced back to the servers so that we can monitor how much naloxone is being distributed and resupply them with naloxone as needed. And that's just been hard. It's been hard. I think sometimes the technology itself is a bit of a barrier. I think that sometimes agencies, that it's just hard to kind of routinize making sure that you're syncing the data every week. Some of the strategies we've used to reduce these barriers, certainly our implementation facilitators are great at providing ongoing technical assistance, trying to troubleshoot what's going wrong with the tablets. We also developed a short, frequently asked questions about the tablets. And then we also have a really short 5-minute video about how to use the REDCap system so that agencies can refer back to that if they're having problems with the data entry piece. The 6th lesson is that it's really vitally important to plan in advance to be able to address staffing barriers. Certainly the behavioral health field has experienced turnover for a very long time, but the COVID pandemic has made that even more severe. And every time a staff member leaves an agency, that's a loss both of somebody who's an advocate or a champion for overdose education and naloxone distribution, and we lose sort of the institutional knowledge about how OEND is going to work in that agency. Of course, it also means we need to update the standing order agreement to remove the staff member who's left. And because we're doing all of this work remotely, it can take sometimes quite a bit of time to realize actually that turnover has even occurred. In the best case scenario, the person who's leaving will reach out to their implementation facilitator and let them know, but that doesn't always happen. And that's another place where having data about distribution of naloxone becomes really important. When we see a drop off in distribution, that can be an indicator that turnover has happened and a sign that the implementation facilitator needs to reach out to the agency. In terms of addressing some of these staffing barriers, I think one lesson we learned early on is to try to make sure we have multiple contacts within each agency so that if one person leaves, we still have other folks who know about the study, know about the work, know about the partnership. Ongoing follow-up meetings by our implementation facilitators have also been really important to address some of those staffing challenges. Sometimes we can find ways to make the process more efficient. Sometimes those follow-up meetings reveal that we need to maybe rethink the implementation plan and the workflow. And certainly as new staff are hired to replace those who have left, training becomes really important, and our implementation facilitators can train those new staff. A couple other ways that we've tried to address some of the staffing barriers. We've done a lot of cross-training of other funded staff through the Healing Community Study to supplement the overdose education and naloxone distribution work. We have a partnership with Voices of Hope. They are a recovery support organization that hires and trains peer recovery coaches, and those coaches are being deployed in a variety of organizational settings. And so we've trained all of the peer recovery coaches in our model of overdose education and naloxone distribution. And we also have a partnership with Bluegrass Care Navigators, where we've developed what's called the Bluegrass Healing Transitions Program. Their care navigators are nurses and social workers, and we've cross-trained them to be able to provide OEND as well. And really, this has provided an opportunity to expand the reach of the program. They can help clients who may have been missed by the agency staff. And also, when turnover occurs, they can fill in some of the gaps when agency staffing is a barrier. And the last lesson I wanted to highlight is that we've had some agencies that really aren't doing in-person services, and so we needed to be able to find a model that would work for them. So we have a mail-based option that some of our agencies are using. We actually had some partners who were already 100% remote before the pandemic. We had some telehealth MOUD providers, but we also had some agencies that wanted to be able to integrate OEND into their agency website. So for the mail-based program, we've had to figure out ways to disseminate information about the OEND option. In some cases, the agency uses letters to contact individuals. They may post the link on their website. In the case of probation and parole, they've actually integrated information about OEND into a web application that they use for reporting purposes. But once a person's received information about OEND, they go online to the Typeform website. And on that website, we've embedded the Healing Community Study Naloxone video. There's a couple of brief knowledge questions and a survey to collect the person's mailing address. I did want to point out the knowledge questions are not a barrier to receiving naloxone. If a person answers them incorrectly, we just show what the correct answer is, and then they can still receive the naloxone. So the agency staff still plays a role here. They have to log into the Typeform website periodically to review the mailing address forms. And then we provide them with U.S. Postal Service prepaid envelopes. So the agency staff just has to put an address on the envelope, place the naloxone and a brochure about the naloxone inside the envelope, and then they can drop it in any mailbox and get it to the participant. So far, this mail-based option, about 32 of our partners are using it. Sometimes it's the only way that they're doing OEND. In other cases, it's just part of a broader implementation. About 19% of our partners are engaged in mail-based OEND. Those types of partners, we've had some really good successes with criminal justice. So probation and parole, pretrial services, and some drug courts are using this model. But we've also had health departments and telehealth MOUD providers who have used mail-based OEND through our program. So I hope that this webinar has convinced you of three things. First, that having a centralized hub with many spokes is a model that can promote scaling up overdose education and naloxone distribution in communities. We've found actually that it's been feasible in both our urban and rural communities, and that there's incredibly strong interest out there, many potential partners that want to be a part of this work. But implementation and scaling up is a process. It's going to take different strategies at different phases, both in designing the centralized hub as well as building partnerships with the spokes. But I hope that this webinar has encouraged you to do this work in your community where it can make an impact. I want to thank the Substance Abuse and Mental Health Services Administration and the Opioid Response Network for this opportunity to build this webinar. I also have to acknowledge the National Institutes of Health and SAMHSA for their NIH HEAL initiative. There are several sites that have been funded under this initiative as part of the Healing Community Study, and I am profoundly grateful to our Kentucky communities, all of our partner organizations, and the Healing Communities Study team of faculty and staff at the University of Kentucky who are working so hard to do this work. Thank you for your attention, and I hope that you will take on this work in your community to help reduce deaths from opioids. Thank you.
Communities across the nation are mobilizing to address opioid and stimulant use and the overdose crisis. You can't overcome this alone, but we can, together, and we are. We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60% and supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We helped healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines. So, what are your needs and how can we help? Visit the opioidresponsenetwork.org to learn more and to submit a request for support. The Opioid Response Network, funded by the Substance Abuse and Mental Health Services Administration.